for the presentation, and thank you for inviting me to this conference and inviting me back to Turkey. I have had the pleasure of being in Turkey a number of times, as I was part of the introduction of the EMRAM model from HIMSS for evaluating the electronic medical record situation in hospitals. And I would say I was really impressed about the things I saw in Turkey at that point in time, so I'm really pleased to be back. Just a short introduction to me. Today, in my daily work, I work in a big hospital in Denmark where I work with telemedicine and IT implementation. And I'm here today to give you a presentation of some of the works that we are doing in our hospitals and give you some insight in experiences we have had in a big European project where we were looking at different types of telemedicine services in Europe. So, my background is economist. That's why I like to put everything into equations. So, this is the conclusion. I will get back to that in the end. You can think about it. Just a short introduction to our hospital. It's one out of 3 main hospital centers in Denmark. It covers around 1.6 million people, and we have around 10,000 employees. It is a little depending on how you are counting the biggest hospitals in the Nordic countries. We are an almost digital hospital. We have been working with IT and IT implementation for many years. We are a EMRAM HIMSS Stage 6 hospital, at least at the moment. We have an electronic medical record covering our hospitals, but also covering all the other 4 hospitals in the region. And we are very well integrated between hospital, municipalities that take care of home care, nursing homes, and the general practitioners in Denmark and in our region. And we have, over the last 8 to 10 years, been looking more and more into using telemedicine as a tool for our delivery of care and services. Because being digital is not enough. In Denmark and in most of Europe, we are facing the same problem, and we are definitely doing it in our region, is that we have an increase in demand. We have new, more expensive treatments. We have increasing number of patients with chronic disease. Not only do they get more chronic disease, they also live longer, which means that we have to care for them longer. We have an increased number of elderly people in Denmark, and we have a decrease in number of health professionals, and we have a decrease in public financing, which is where the hospital and healthcare system in Denmark is paid from. So we are looking at big challenges in our hospital to provide the necessary care and quality in the future to our patients. So we look at technology as the many tools that we have to use if we want to provide good services for our citizens in the future. And we know as a hospital we cannot do that alone. If we want to create new services and good services, we need to partner up with our industry partners that delivers our IT system, because we may, as a hospital, be really good at actually delivering care at a high level, but we are not IT specialists when it comes to develop new services. We also know, as an academic institutions, as an academic hospital, that it is important to have science connected to the development that we are doing. So there's a close link between our daily productions, the industry, the vendors that helps us, and the university and the scientists that are working. That's the triangle that we are trying to work on. To do that, we have created an innovation model that helps us in organizing the way that we are trying to build our projects and trying to develop new services. One thing is to get a really good idea for a new service. We get a lot of them. Our clinicians get a lot of them. Second thing is to actually find out, is this a good idea? How do we do it? Is there something at the market? But we need at the same time also to see what have others done, and is there a good business case from the hospital in that. If that is the case, we start our projects together with the industry, we develop the service, we test it, and if it turns out to be a really good idea, we in the end implement it in the daily production. But we try at the same time to build a good business case for our board of managers, for the industry that are there. So we have a process about business case, and in the end we have lean to secure the implementation. And at the same time we are working with research so that we create the necessary documentation of the services, the clinical documentation and the economic documentation. So that's how we try to combine the three things. Now, to give you some practical example of what we have been working with and implemented in our hospitals, some of the service is just take technology that is there and use it in a different way. So video conference has been on the market for many years. It is, even to a certain degree, possible to work across hospitals. So when we realized that we needed to change the way that we are collaborating with other hospitals and we could not have physicians driving around on the streets, we implemented video conferences in large scale in our hospital to have clinical conferences, to have specialist to specialist discussions. And that has been running now for a number of years, as is increasingly used in daily production as a way of communicating specialist knowledge to other hospitals in the region and outside of the region. What really started it was that in Denmark we have a number of people who need language interpretation when they go to the hospital. And in the beginning we had interpreters coming into the room and doing the interpretation. We replaced that situation with a video conference system. So now we have a video language interpretation network sitting somewhere in the country. And all we need to do is, when we need interpretation, is to bring in a video conference equipment into the room with the doctor and the patient. Surprisingly, they totally changed the relationship between patients and doctors, because now it was a direct conversation between doctors and patients. We did it together with Cisco in a small trial. After 3 months, we realized this was a really good idea, and we scaled it up to a regional and to a national service. And it has been running now for some years. What really kicked it off in our hospital was that the management changed the payment system. So if a department requests interpreter to come to the department pays. If they use video conference, the hospital pays. And that totally changed the use of video conference in the hospital. Another area that we are looking into at the moment with a great potential is psychiatry. We are running at the moment a big EU project called Mastermind that is trying to provide telemedicine services for depressed people. And we have two types of telemedicine service. One is an online cognitive behavior training tool, and we have video conferencing for treatment of patients and for collaborating between patients and healthcare professionals. This is a quite ambitious project. We want to make sure that the services are able to be upscaled. We want to make sure that it can be used in other countries. We also want to demonstrate that this is a cost-effective way of treating depressed people. And we want to reduce waiting lists in not only our region, but all the participating regions for treatment for depression. We also want to increase the access to treatment in our services. One of the problems is in the Danish healthcare system, we are centralizing a lot of services, which means people that are living far away get difficulties getting the services, but having online services, you can give them more equal access. We want to demonstrate that whatever we do is transferable across Europe. So if we get a good success in one region in Europe, that results should be transferred to other regions. And of course that this is safe and it's possible to organize your services in a different way so you can provide the service. We have partners in the project across Europe, actually from Greenland to Turkey. So we are covering the most of Europe. And it's quite interesting to see how you can provide the same services with different tools and different healthcare organizations, but get to the same results across Europe. We're really looking forward to get the results of this project. Another area in Denmark is that there is a big fragmentation of responsibilities between hospitals, municipalities, home care organizations, and GPs. And what we have seen is that we are really good at communicating between all these systems. But we are not so good at actually getting the same, all data, relevant data, at the right time, at the right place. So at the moment, we are collecting all these data from municipalities, hospitals, GPs, and the patient themselves in what we call a shared care portal for chronic disease management. So this new portal will give access to all relevant data around the chronic disease to all 4 participants in the treatment process. It's not that easy when you are working in a system where you have different decision makers and different IT systems, and to integrate and get that on board, but it's what we are running at the moment, and it seems like a way forward. We have also been working with telemedicine on a European level. We have been a part of a big European project called Renewing Health, who had the purpose of getting scientific evidence of the value of using telemedicine within 3 areas, diabetes, COPD, and heart disease. We did that in 9 regions in Europe and with different diseases. But what brought it together was that we used the same evaluation model. The background for this project was that the European Commission has spent a lot of money on telemedicine projects, and there was really little uptake when you looked across Europe, and there was no large-scale implementation. One of the issues, according to the Commission, was that there was a lack of good scientific evidence for this. So they initiated a project that should, first of all, develop an evaluation framework that could give us the same way of assessing telemedicine services. And we did that together with people from Tromsø in Norway and Scotland. So we developed the MAST model, which builds on health technology assessment, but is adjusted to telemedicine services. It has 7 domains that you have to look into if you want to produce a good scientific study around a telemedicine service. And we applied that on the 18 different trials that was in Renewing Health. It was a big project, more than 7,000 patients. It was a complicated project, coordinating between all the participants in the regions. In the Danish part of the trial, we had 2 services. One was at the diabetic foot ulcer services, where we moved the treatment of the diabetic patients' care for foot ulcers out of the hospital into the municipality, supported by a web interface, a web tool. They could, with their mobile phone, take pictures, upload it, and get support from the clinical specialist at the hospital. And by that, we were able to transfer the responsibility and the treatment of the patients from the hospital to the municipality. That was included in the project, and we are not quite finished yet, but we had around 400 patients in that, and there's unfortunately not results until the end of this year. Another project that we had was about COPD, home hospitalization of COPD patients. When a COPD patient comes in with an exacerbation, they normally stay 4 to 5 days in the hospital. That goes fast. What we did was we installed this equipment at the patient's home, discharged them after 1 day, and they were sent home. And then we had teleconsultations by nurses every day, and they were measuring pulse oximetry and spirometry by these patients for 7 days, and then they were discharged as normal. And then they were back to the normal life as if they has been in hospital. So by the help of a very simple tool, it has only video conference, it has the measurements equipment, it has 3 buttons, on and off, volume, because this is elderly patients, and an emergency button. We were able to treat the patients in their own home instead of having them in hospitals. In the trial, we did these measurements to see if this was a good idea. The results of the clinical trial was there was no significant reduction in readmission. That was our assumption, that we could reduce readmissions. We also saw this was quite expensive, that we could do the treatment. The patients was really happy. No doubt about that. The patients love it. They hate to be in hospitals. They love to be at home. But when you looked at it at that point in time, we could see that there was more cost to it than we expected to save. Well, I think that's also my conclusion. If you just implement new technology, and if you don't change your organization, you will just get a costly old organization. And this is exactly what happened in all the telemedicine project. We implemented a telemedicine service, but we didn't change the organization. We didn't reduce the existing services, so we didn't capitalize on the investment that we did. And this is, you could say, the outcome of all the trials we did. It will give you what I normally say: we don't kill more people than we normally do. So it's safe. The patients love it, no doubt about that. But if you don't change your organization, you will not get the benefit from the economical point of view. And that, I think, is the conclusion of all 18 trials. Some of them shows economical benefits, but it's relatively little compared to what we were expecting. So you can implement telemedicine. You can do it without having problems with ethical, without having problems with safety. Technical problems you will always get, but you can solve them. Changing your organization. Convincing the clinical staff at the next hospital, this is a brilliant idea. That's the trouble. So remember this. Also change your organization when you want to implement telemedicine. Thank you.
Thank you. If there are any questions, you can answer. Monsieur Vejan.
Thank you. Bülent Becan. I'm very, very, very happy to be here now to listen to you. I have a question about your your equation, which is the last one. Do you think that it is old organization or old mindset? What I mean is the following. If you can change the mindset, which is more difficult in Denmark than in Turkey, do you think that if we change the mindset, it could show more financial benefit? This is my question.
It's an interesting question, and I think that from my experience, you need to do both. You need to change the mindset. You need to change the mindset of clinicians that they in the future is going to work differently. And the only way you can, no, not the only way, but one of the important tools in that is to create good, solid clinical evidence that this is something that actually is safe, give benefits to the patient. So you need to build up evidence, and that's the whole thinking behind the European project and this evidence. So you need to build evidence. You also need to work in many different ways with the clinicians to say this is something different. You will not lose money. You will still earn money and things like that. You will just do it in a different way. But for instance, when we did implemented the COPD suitcase, and this is nurse-driven, and nurses said that this is no, we cannot do that because we cannot touch the patient. When you are a nurse, it's really important to touch the patient. But they learned that they could have the same proximity with the patients when they were looking in a video. Actually, they had a more close relationship to the patients over video than they were having when they were in the same room with them, because then they were interfering and things like that. So they learned, and now they need to transfer that knowledge to other nurses, that you can actually do it on video and get the same level of good nursing quality. The second thing is you need to change organization. First of all, you need to change reimbursement structures. Because if you don't change the money flow, nobody changes anything. And this has been really difficult in Denmark. Hopefully you are better than we are to do that. We are not adaptive in our reimbursement systems. Well, then you have an opportunity. It took 4 years to get a reimbursement for the COPD suitcase so that we actually could implement it and run it as a service in our hospital. So you need both. You need good evidence, good practice and good stories, and then you need organizational changes and reimbursement changes.
Thank you. Is there any other question?
Thank you so much for your presentation, Duedal from GSK. We have similar initiatives in Turkey, but not at this level, of course. I was curious on how do you ensure the data safety, the data protection of the health data?
Well, it's one of the long discussions we have had in Denmark also. You could say we have a set of rules, regulations around that tells us what to do and what not to do. We have to follow that, and we will, of course, follow that as a public hospital. Secondly, I think if you do it right, it's not a problem. You just need to have people that actually take this serious to do that. So we have encryptions and whatever is needed to follow the regulations. We have inspections from the Data Protection Agency. We had that to ensure that we were not storing data at the patient's home and things like that. So it's something we spend a lot of time on, also a lot of money on, but I think it's not a problem. It's something that has to be done, and some people, and this is not me, some people who really knows about it, they can do it, and so that's what we made. You need to follow regulations. You need to make sure also to be able to have to be trustworthy towards the patient that their data are safe. So you need to do it right, and you need to spend time and money on getting it right. And there you need the specialists.
Last question. Okay. No last question. Thank you very much, Mr. Petersen.